Good afternoon, everyone. To start with, a big thank you to organizers for allowing me to share some of my experiences over the last couple of decades from Ireland with you. A particular thanks to Dr. Lalu Joseph and Dr. Agarwal for introducing me to Caho. It's a great faculty and a great family. And this occasion is special for me also because it's almost like a homecoming to my roots. I'll touch upon some background. What is cost and what's value? A preventive neonatology. We heard about the critical care. And is there something we can do to avoid the critical care if possible? Some evidence, and throughout the talk, I'll be touching upon evidence which you can create, which you have the power to create. We are very much interested in patient care, but through the patient care, I think particularly for the youngsters, you should try to create evidence. And some quality examples, if we could do it, you can 100% do it. And trust and some clinical research. So the top hospital there is the Rotunda Lying In Hospital, where I went to get training in neonatology after my MD from Trivandrum. And that hospital is a brand new hospital started in 1745. It is the oldest functioning maternity hospital in the world. And the next one is where I did my fellowship in critical care and ECMO, that is Great Ormond Street. That is again in 1852 or around there, and now I work in Limerick in Ireland. Now the other important thing is I had an opportunity to look at so many health systems with my presidency of Irish Pediatric Association. That gave me a great opportunity, including coming to India on so many occasions. Why is cost and value in neonatal care very important? That is 2000 to 2017 WHO in under 5 mortality. Of that, 28 days will account for 47% of the death. And the most important thing is India has 25 million babies born every year. One of the highest, not one of the highest in the world. So if you are the champions in having the babies, we have to look at how to prevent with value-added measures. And if one of these babies come to our unit, this is what I do all the time. Money flows with the patient. That means the unit is funded, additionally the department is funded, and the patient care goes on. Whereas in many parts of the world, it is not money following the patient, it is money flows from the patient for the care. I am not asking here what's happening here, but I know what's happening. This was a Time publication a few years back, which said this baby is likely to live for 142 years or so in Western Europe. It may sound like a science fiction, but the way things are going could be true. And if that is the way, then it is extremely important that we do value-added measures at low cost, particularly in India, to see what we can do for them. And if that is the case for the full term, then think about that 23-weeker who is next to the baby. And what about the preventive neonatology? It is not what is happening in neonatal intensive care unit, which we think that is where it is. It is about the 3 most important mortality reasons here and elsewhere: infections, prematurity, birth asphyxia. If we can even reduce it by 5%, it is going to save so many lives in this country, because there is every minute 1 baby is dying out of the 25 million born in this country. So we have to start at the pre-conception, peri-conception, antenatal, perinatal, and ICU, and afterwards. So I would like to mention a few very low cost, which anybody can do, evidence-based measures. Hand hygiene, it costs not much. Neonatal hypothermia prevention. So many things are written by the National Neonatal Forum, Indian Academy of Pediatrics. Please make sure that not only the big centers do it, even the small centers do it. Neonatal hypoglycemia prevention, there are so many simple measures we can do it because it can lead to issues. Neonatal resuscitation, I'll come to that in a few minutes. Early and exclusive breastfeeding. I'm a very big proponent of breastfeeding, and so I'll be touching on a couple of minutes on that. Antenatal steroids for preterm birth prevention. Where the biggest evidence is there, is it actually happening? We have in our hospital 95%, irrespective of who they are, they get an antenatal steroid if they are anywhere preterm at all. Magnesium sulfate for very preterm, and you can have a little. And the last one is maternal immunization, which through COVID, it actually gave a sudden resurgence as well. Some of them are moderate expense to get a high value. It may be about anomaly scans during pregnancy, newborn hearing schemes, neonatal metabolic screening. But when you look at the value which you're going to get out of these, they are more valuable than buying many neonatal ventilators for a specific number of patients. Family-centered care models is becoming a big thing in the West, and I am very sure it is going to percolate here as well. And neonatal critical care transport could be expensive, but it also saves lives in the right settings. I mentioned about evidence. And when it comes to evidence, the best picture is of Cochrane database. And that picture which you see there as the logo of Cochrane is actually the exact randomized controlled trial picture that is taken from Patricia Crowley's work in the National Maternity Hospital in Dublin, which conclusively showed that antenatal steroid is a very low cost, is able to reduce respiratory distress, able to reduce IVH, and so on. So try to adapt it because that is the picture which is the logo of evidence. When it comes to breastfeeding, I'm not sure whether I have any right to talk about it. I'll tell you why. But there is every opportunity to reverse that picture as the arrow is with early and exclusive breastfeeding. Ireland is extremely bad in breastfeeding. Ireland is one of the worst countries in the world for breastfeeding. Our initiation rate is only 63%. That means before the mother leaves the hospital, only 63% is even attempting it. It will come to single digits by 6 months of age. In a country like that, we could bring through a QIP, started about 10 years back, 100% breast milk uptake for extremely low birth weight below 1,000 grams. And for the last 6 years, not a single baby in our unit, which is less than 1,000 grams, is not exposed to breast milk. So in a country like that, if we can do it, you can 100% do it. So simple measures which may improve, and we prevented necrotizing enterocolitis for 3.5 consecutive years with 0 neck. So there are simple things we can do. It is not very costly. It is never withdrawn from the market. Use it as much as possible. Then another area which is very high value and reasonable cost is maternal immunization. I am very glad that maternal immunization got a very good thrust with the COVID vaccination saga. But the minute we talk about maternal immunization, we talk about TT or tetanus toxoid. It is time to go beyond that, to go to pertussis, to go to the future immunizations which may be coming over the years, group B streptococcus, RSV, and so on. So maternal immunization plays an important role in the life course immunization, low cost, high gain. But in order to improve the immunization, just will not be happening if you just say it. You have to improve the convenience, enhance the confidence, and complacency has to be removed, and you have to be mindful of the cultural acceptance. These are all things we can do, actually, if we are really interested to do it. And one of the other things I was mentioning was family-centered care. Neonatal intensive care, as you all know, is one baby stacked on to the next one, and infection will be spreading, outbreaks will be happening, and this is moving towards family-centered care. In the next picture, we will show a family-centered care room, but that looks very posh. That doesn't mean that that is the way it should be. The same principle can be adopted with less expense in the family-centered care centers, which is coming in many other parts of the world. So it may be the mother will be staying, the father could be staying, and we cannot think of any intensive care baby of a 28-weeker with a sibling like that. And we call about the kangaroo mother care, and we call as an acronym called KFC for kangaroo father care. So all of these things are happening, and they are low cost, high yield. And now a couple of big ticket items. Big ticket is if we are going to really don't do well, we will or we might pay through the nose. Litigation is only beginning to show the full picture here. But if the neonatal resuscitation, as suggested by the Indian Academy and the National Neonatal Forum and previous speakers mentioned about practicing it and perfecting it, then it can avoid millions in compensation. This is our last compensation case of 2021, a cerebral palsy birth asphyxia in a nearby hospital settled for 30 million euros. It may not be immediately coming, but not only that the medical system is coming to this country from the West, the legal system is also coming to this country because many of the Indian laws are actually foundational on the British and Irish laws. Just be mindful of that. That doesn't mean that every baby has to be coming through a section either. So if you look at some of the countries, at the top, it is over 50%. I remember going to one of those countries a few years back and asking the audience, oh, what is the section rate in your hospital? And after that, somebody said, don't ask people to lie in public. So I am not asking at all. So, but it may be highly variable, but something to be mindful of. And if this is the baby in a typical intensive care unit, there will inevitably be infections, outbreaks. With 25 million babies born in this country, with so many preterm and so many in intensive care, the number of outbreaks has to be significant. But the number of published outbreaks are limited. Just be aware of what is going on, just be honest about what is going on, and that is only going to add value to your care. That's what I said. Respond, recognize, and reassure if outbreaks happen, rather than saying nothing is happening there. And one of the other areas is for benchmarking. We started benchmarking in 1996 when I started initially on the Vermont-Oxford network. We are talking about benchmarking here. It is the biggest neonatal benchmarking system of the world with over 1,400 centers, and the whole of Ireland, it is benchmarked. So we will know where we are against every other unit in the country, and where we are against everybody else in the world. So I heard a lot and learned a lot this morning about the importance of benchmarking here. Whichever way it is done, whichever link up we are going to do, but benchmarking is fantastic because it will tell you where I am and it will also guide me where I should reach. And one important reason why we do all these things, all this quality, everything is for one thing actually, it is trust. Trust is an important thing. It takes years to make, seconds to break, and very difficult to patch up. So retain, reinforce, and repair the trust of simple measures which we can do. And if Lancet Global Health is telling preterm birth is very high, and the highest preterm birth actually is happening here. And I will touch upon the research in 1 minute, and then I'll stop. So during the pandemic, I have to say something about pandemic, isn't it? So we observed that we have a very good data system, so I could look back for the previous 20 years, what was happening for our preterm births. So you can see from the graph, it is self-explanatory. It dipped like anything during the lockdown. And simultaneously, almost 5 days apart, almost the same graph was published from Denmark, identical. So with these two papers coming out, it created a big interest worldwide. And a paper is going to come from 26 million baby analysis over the coming weeks in Nature. So I think, and it went on to New York Times, and it created a huge hoo-ha. Small observation, and act on it, mainly for the youngsters. I think if you see something, say something. There may be a true observation behind it, and learn to get it analyzed correctly, learn to publish it. It's not difficult. This is the new picture of neonatal care. That is a picture recently was becoming a big interest of an Ukrainian neonatal nurse holding, I'm not a big expert in what type of AK-47 or whatever he is holding. So it all talks about price, value, cost. And the value is quality divided by cost. So thank you so much, and it's a great opportunity to share some time with you. Thank you.